Good evening, all the aspirants present here. Well, today's topic is infectious disease tropical medicine. Have here is Dr. Anand Joshi. He is a consultant intensivist and physician at Government Hospital, Hyderabad. Sir, you may take over. Thank you.
Good evening to all. Welcome to another session of infectious disease and microbiology, which are medically relevant. Um, we this will These are going to be a series of lectures, which I will try to cover most of the infectious disease related topic. Um, uh, so this will be the first one, and subsequently we have other different diseases which we will be covering in subsequent talks. I always say this, that humans are very smart organisms, but we know that we know, or rather we think that the humans are very smart organisms, but we forget that we are not the first one to come on this earth. The first unicellular organism is assumed to be started from the viruses that gets bit complicated with fungus and then the bacteria. So bacteria, virus, and fungus are the three forms of living organisms. And remember, all these three organisms survived all the Stone Age, Bronze Age, even the mighty dinosaurs came and got vanished. However, bacteria, virus, and fungus remained the same. The last probably to come were humans. And we humans, if we think that we can rule this world by eliminating all the living organisms, then I think we have to rethink our intellect. These are the virus, bacteria, and fungus are the organism that has survived everyone. So if we think that we can eliminate all of them completely, then probably we are not being realistic. This first talk, I'm going to cover what we call it as a medically relevant microbes and antimicrobial classification. In this, I'm going to just give a complete overview of important medically relevant bacteria, virus, and fungus. Of course, we do have protozoas and other parasites, which are it will be too large and it is out of the scope for this current talk. I'll be covering them later. Now, for these bacteria, virus, and fungus, when they enter into our body, it's always the survival of the fittest. If you see in the Darwin's theory of evolution, or even if you see, there always been a survival issues with any of the organisms. Every organisms need food, and they thrive on other organisms or the living thing for staying alive. And that is also true for bacteria, virus, and fungus. At the same time, each organism has a right to defend and try to kill the other organisms. So hence, the defense or the immune system of the humans come into the play. So when we say that we are infected by some organism, particularly now we will be talking about bacteria, virus, and fungus, we are talking about the entry of this organism inside our body. Now, when these organisms enter, obviously the immune system is trying to defend, and in this process of defense, whatever the sign and symptoms develop, that is how we recognize that somebody has entered into our body. Our body, including the skin, is all inhibited at some point of time with some various organisms. Our oral mucosa, our nasal cavity, some organisms stay there, but they stay with a symbiotic region. When they breach the barrier, and the first barrier being our mucosa and our skin, and enter into the system, that's when the problem starts. Now, we've been here for thousands of years, and there we have seen that whenever this infection enters into the body, they tend to kill the humans, and the humans die. So to counteract them, humans anti uh, discovered antibiotics for the bacteria, or antimicrobials for bacteria, virus, and fungus. So we have bacteria, and we have developed antibacterials for that. We have virus, and we have antiviral for that, and we have fungus. We have antifungal for that. While these sound to be very, very, very basic thing, the reason I'm insisting is that you stop yourself and just look around, or see what you have done in the recent past, or you have seen some around. You'll always come across certain things like, oh, he's got viral infection, let's give him some azithromycin, isn't it? How many times we have seen that happening? And we forget that there is a contradiction in what we are speaking. At one hand, we are saying it's a viral infection, and at the same time, we are giving azithromycin, which is an antibacterial. And the same thing, we get satisfied that if the patient is very sick, or the patient is having um, a very clear cut signs of that it's been infected, without giving a thought, we assume and presume that it's a bacteria, or whether I'm not sure whether we assume there or not, we straight away start with higher antibiotics like meropenem. Many times I tell my students that I don't have problem in you guys starting on a broad spectrum antibiotic or antibacterial, but my problem lies that people stop thinking. They don't try to correlate or try to find out whether this is actually a bacterial infection, or it is anything else, or it's just a bad virus, or whether it's a fungal infection. So hence, my my request to all the people, all the students, is that always try to be mindful of what you're treating and what you are trying to treat. Yes, the most common being the bacteria, sickest one will the bacteria. That's all right. You can start a broad spectrum antibiotic, but don't stop thinking at this place. And if any point of time when you come across this is not a bacterial, try to stop the antibacterial and see whether you need to add any antifungal or antiviral. So with this introduction, I'm just going to broadly classify and broadly have an overview of medically important bacteria, virus, and fungus. It's going to be a bit longish. I may not be able to cover everything, but I will try to cover as much as possible, which is also relevant from the exam point of view. So we'll start with the bacteria. Now, let's look at the structure of bacteria. It's very important that at least we have a bit of a basic idea how the bacteria will be, looks like, and what it has. Couple of things which are very distinct for bacteria is that it's got a peripheral wall, and then you have the internal organelles. This peripheral wall has got a capsule, has got a cell wall, has got a cell membrane, and then we have all other organelles such as plasmid, sex pilus, attachment pili, flagella. Then we have nuclear DNA, cytoplasm, and ribosome. The reason you need to know that why these things are there is one, some of them are responsible for entering into the body and stimulate the immune system, which we call it as a virulence factor. Anything? Any question? Yeah. And some of them are becomes what we call it as a virulence factor, and some of them become a resistant factor. So just knowing that these things exist in a bacteria is very important. Now, how do we recognize the bacteria in the laboratory? Now, recognizing the bacteria in the laboratory is becomes synonymous with the classification of the bacteria. This like India is a vast country, and we have this male and female, but however we are able to reasonably find out how from which part of India this person belongs. Now this may come out from the features, this may come out from the morphology, this may come out from the language they speak, this may come out from the dresses they wear, this may come out from the food they eat or food they cook. In the similar fashion, there are different ways where we can try to identify these bacteria, and these ways have been very helpful in diagnostic methods to find out whether these bacteria are from the which classification. So the most common thing which we look into is what we call it as a gram staining, which you, I'm sure, as a microbiology, you have seen it. Now, gram staining is essentially to stain the cell wall composition. So the outer cell wall which we see, that is what the cell wall composition we differentiate. So when we call it as a gram positive, then there is an uptake of crystal violet or purple color by the thick peptidoglycan, and this we call it as a gram positive. And when it takes the another dye, what we call it as a safranin dye, then we call it as a gram negative. Just to keep it very, very simple, we can call it as a gram purple or gram violet, or we can also say that gram saffron or gram red. But just to keep the things very simple, we say it as a gram positive or gram negative. So this is the first step where we differentiate the bacteria as a gram positive and gram negative. The next comes the shape of the bacteria, or the more how they look like. Some of them are spherical. We call it as a cocci. The other are comes as a rods. We call it as a bacilli. And the examples, as you see, are the Staphylococcus, Streptococcus, Neisseria, and other are like rod shape, like Bacillus, Clostridium, E. coli. Then we have a spirochete, which are like a flexible thing, and then we have a curved rod, which we call it as a vibrio. So these are the four ways which you will see. Now remember, these four forms, like spherical, a rod, a curved rod, can still be a gram positive, they can still be a gram negative, right? The third form is whether these bacteria are able to form any spore. Why we need to know this? Because these are the highly resistant dormant structures. So these organisms can stay dormant for a long in the environment, and then they grow when the conditions are favorable. And these are resistant to heat, chemical, and dissection. So that becomes another thing when you are talking about a when we are talking about sterilizing the things, or when we are looking at the antiseptic methods which you are trying to use, and some of these spore forming bacteria may not get eliminated. The fourth way of, as we know, bacteria needs to grow, and there is a diverse need. Some require oxygen, some cannot require, do not require oxygen. Some grow probably with or without oxygen. Some require a very low tension of oxygen. Some require, can tolerate oxygen, but they don't use it. And then some require high CO2 require. So primarily we focus on, when we talk about it, we call it as aerobes and anaerobes. Now remember, this can be a multiple permutation combination among this gram staining, bacteriomorphology, spore, and oxygen, right? Now these are the ways which we help to classify our organisms. Now there is something called as bacterial virulence factor. So knowing these virulence factors becomes very important, especially with the mode of destruction they form, more the way they enter into the body. So we have a pilia fimbria, then we have glycocalyx, or the capsules. So the importance of this capsule and glycocalyx especially has come into being when you are now talking about sepsis, septic shock, and there are with the resistant organism. That's where the importance of knowing this part of the bacteria is come up. Then we have exotoxins, we have endotoxins. The exotoxins again are very important because these bacteria might be somewhere, but the havoc which is created or the inflammation is created is because of the exotoxin. The direct relationship comes when there is a tetanus, diphtheria, or we have staphylococcus, streptococcus, and they cause toxic shock syndrome. So in this case, we not only have to take care of the bacteria, but also we have to try to see if we can neutralize these exotoxins. Then we have endotoxin, such as lipopolysaccharide. Again, these lipopolysaccharides get released, lysed, and they end up causing a septic shock. There are certain super antigens, they hyperstimulate C cells, as I said, and cause a massive cytokine release, example, as we see in toxic shock syndrome. And then you have immune related virulence factor also that cause more of an antiphagocytic capsules. Everyone with me so far?
Yes.
Right. I'm just going to take this thing bit down. Now, let's get on to the little bit of detailing of medically important bacteria. This is not necessary that you have to keep everything in your brain, but once or twice, if you come across, once or twice, if you have gone through, because I'm sure after second year of MBBS, hardly anybody goes through this, but this becomes very important because especially if you're treating a very sick patient and you get a call from the microbiologist and you said, "Oh, doctor, I don't think this is a different organism. This looks like some gram positive rods I'm seeing, probably aerobic in nature. That's all I can see." Now, the culture takes its own time to grow and you have no clue. And then these information, if you get some sense, okay, gram positive, okay, this is aerobic, so probably this is what I'm looking at, especially given the clinical that this person had some intra-abdominal abscess or this patient has some cellulitis, and probably gram positive. If they are round spherical cocci, then probably I'm looking at staphylococcus, something like that. So you may not be heavily dependent on any other organisms or antibiotics, and you can think that, okay, let me focus on the gram positive coverage, right? So to start with, we'll start with a rigid thick wall, because that's how we started. It's a wall base. So if it's a rigid thick wall cells, remember there is something called as most of the bacteria or extracellular bacteria. And when we say that there is an extracellular bacteria, that means there are few intracellular bacteria. Why this is important? Because sometimes these intracellular bacteria are hard to kill, because the antibiotic may not reach inside the cells, and in which case you have to choose some antibiotic which has a higher intracellular concentration. So those are not many. Majority, 80% of the bacteria are what we have, this extracellular bacteria. Now again, gram positive, gram negative, which is a very common term which we use. Gram positive, again, cocci, and gram positive rods or bacilli. Now, gram positive cocci, commonly it's Streptococcus staphylococcus, and which is most commonly Streptococcus you see. It's you see in pneumonia, pharyngitis, and cellulitis, and Staphylococcus mainly skin and other integuments. Then we have bacilli. Again, bacilli will be spore forming, non-spore forming, and in that, those who take oxygen, there are those who do not take oxygen. So we have Bacillus anthrax, and then we have Clostridium range, where we have tetanus, gas gangrene, and botulism. So it becomes an anaerobic Clostridium spore forming rod. What does, and those are also gram positive. So gram positive anaerobic spore forming rod. So if somebody comes to you, a diabetic with a gangrene thing, then you know probably you might be dealing with some Clostridium guys, which has caused a gas gangrene. And the fact that these doesn't need any oxygen to survive, or they require no oxygen to survive, and they are hardcore thing because they are spore forming. So the spore may be resistant to the routine things. So now you have an idea what kind of organism you are dealing with. The other non-spore forming rods will be Corynebacterium, that we have diphtheria, then we have Listeria meningitidis, then we have actinomycosis and nocardia. These are the things you may not come across very commonly. However, some places like Listeria monocytogen, this is where you should keep in mind. Diphtheria again is straightforward, and nocardiosis again you will be coming across in a I won't say immunosuppressed, but immunodeficient person. Coming to gram negative, again the cocci will be the Neisseria meningitis, which causes gonorrhea and meningitis. And then you have rods, where we have a facultative rods, which are straight. We have a Haemophilus, then we have Bordetella, Legionella. So Haemophilus influenza, you more commonly found in meningitis. You have Bordetella, whooping cough in kids, and then you have a Legionella, which we commonly see it as a atypical organism. Remember, they are gram negative organisms. Other, which we call it as a zoonotic organism, that is, they are primarily found in the animal and then they get transmitted to the humans. You have Brucella, Francisella, Pasteurella, and Yersinia. They are all at some point of time you have seen in the books. They are important and they need to be kept in mind. Remember, they are gram negative rods. Then we have what we call famous, and which is very, very common with us. So once the lungs, we saw that for Staphylococcus, Streptococcus, and Legionella. For the gram positive and gram negative, we also have enteric related organisms. So these enteric related organisms, now you know, which are which you find in genitourinary or abdominal sepsis. You have all of them. They are all gram negative rods, right? And they are rods, gram negative bacilli. So we have E. coli, Enterobacter, Klebsiella, Salmonella, Shigella, Serratia, all of them do cause pneumonia, but predominantly they will be genitourinary and enteric. Hence, they are also called as enteric organisms. Then we have other Campylobacter, Helicobacter, and Vibrio cholera. As you see, they are all below the diaphragm or enteric related organisms. Gram negative, again, bacteria of interest will be the Pseudomonas. Now, Pseudomonas is a very notorious. It comes everywhere. It comes in lungs. It comes in as a pneumonia. It comes as abdominal. It comes as a urinary tract. Now, anaerobic, particularly the bacteroids, they are the one which you will be seeing commonly in your oral cavity. And when these things go bad, they end up more of an abdominal problems. The third thing we have seen that their organisms are classified as gram positive and gram negative, but there are few organisms whose wall do not take gram positive, they do not take gram negative. But a third stem, which we call Leishman stem, we call it as an acid fast bacilli. And one of the biggest range is a example is a mycobacterium. There are other 3 to 4 list of organisms that causes acid fastness, but the most common is a mycobacterium species like Microbacterium tuberculosis, Mycobacterium leprae, atypical Microbacterium avium, intracellular, and then we have nocardiosis also, and there are 2 more which I'm not able to recollect now, but most commonly the acid fast bacilli. When we are talking about mycobacterium. Then we haven't, as I said, we all these organisms were extracellular organisms, but there are few which is going to go and sit inside the cells. We call it as a obligate intracellular parasites. They are rickettsia and chlamydia. Now, chlamydia, you look into more of an urethritis or sitter, or you call it get trachoma or psittacosis. Now, all these organisms, remember, has had a outside rigid wall. Sometimes there are few flexible, thin walled. We call it as a spirochetes. Not we don't come across very commonly, but yes, we do often come, especially during the some rainy seasons. We get Leptospira, Treponema, Borrella, and then we have a atypical organism, which is a Mycoplasma, which is commonly seen as a pneumonia. So these are the broad outline of medically important bacteria, where we saw them as a rigid, thick wall, which has gram positive, gram negative. And then we had acid fast, and then we have intracellular obligates, then we have thin wall, and we have wall-less cells. So to destroy or to counter these bacteria, we develop antibacterials. Now, when we develop an antibacterials, few of these drugs were able to kill the bacteria, and few of these drugs couldn't kill the bacteria, but they prevented the multiplication of the bacteria. So when they, hence these antibacterials got classified as a bactericidal drug and bacteriostatic drug. So how does these drugs work? So when you add a drug in a viable bacteria, in a viable medium, then the bactericidal drug will completely destroy the bacteria, and then immediately as you see in the graph, the number of viable bacteria will go down. When there is a bacteriostatic drug given, then the multiplication of this bacteria goes down, The number of viable bacteria remains the same, and they continue to remain the same till the um, antibiotics are there. Once the antibiotic is removed, then suddenly you see them growing again. Now, why do we need to? That means that these bacteriostatic drugs are like a useless drug. Why should we have them at all if they are not going to kill? Sometimes we remain dependent on our own immunity uh, to take care of this. See, antibiotic came now. These and bacteria, virus, fungus, and the humans are been there for thousands of years. If the things were so lethal, and if the antibacterial or antimicrobial was the only answer, then we would have been either of us, either bacteria or human race, you would have completely got destroyed. So there is something in the human immunity which says that okay, you can still survive and we have a capacity to kill the organisms. So these aspect comes into the play when we are using the bacteriostatic drug, and we depend heavily upon our own immunity that's going to take care of it. If the bactericidal drug is there and if the bacteria is susceptible, that's fine. Our immunity is less burden. At the same time, immunity will do its job if there is a bacteriostatic drug. So none of the drug are useless. When we are targeting somebody, then we need to know what are we targeting, and some of these antibacterials targets the various aspect of the various components of bacteria, and they try to destroy that, so eventually the whole organisms dies. So we know that there is a cell wall, we know that there is a cell membrane, and then we know that the bacteria thrives with its DNA, RNA, and then we also know that they need some protein things for protein synthesis for the ribosomes. Now all these things are targeted by the various in a various way, and that's how we classify our antibiotics, that is antibacterials. So the common examples, as you can see, those who inhibit the cell wall, penicillins, cephalosporins, and carbapenem. These are the very favorite and common things which we use for everyone, including vancomycin. The one which disrupts the inner cell wall, we've got polymyxin, daptomycin. The one which inhibits DNA and RNA, we have fluoroquinolones, rifampin, metronidazole, and sulfonamide. Those who inhibit protein synthesis, we've got macrolides, we've got linezolid, clindamycin, aminoglycosides. So these are the broadly, these are the targets, and these are the groups of the antibiotics which are going to destroy this organisms. Now let's see how these antibiotic has a selective spectrum. So I could have I have tried to get this table, which I found it very good, because if you go by the theory, or the if you go by the paragraph, it was very hard to remember, at least for me. So I have kept this. I had this table before, but this is an updated table. Now you can see here. So one is first one. Let's see the cell wall synthesis, and had these groups. These groups are called as beta lactam antibiotics. Why? Because there is a beta lactam ring on that. Now, these beta lactam rings are responsible to make the holes in the cell wall, and they are the one which will go and destroy the cell wall and kill the organisms. The most common, most earliest were the penicillins, because the penicillin was the first antibiotic to be discovered, as we know. Now, penicillin per se had it's a big question, and we had a natural penicillins and we have an aminopenicillin, depending upon how much of the anti bacteria they are covering. So initially, the penicillin G was there, benzathine penicillin was there. I don't think anyone is using now, especially in India. However, they are still being used in other countries, including UK, US, and Australia. Then we have ampicillin, amoxicillin. Then we have what we call it as a nafcillin. Now, there is something called as penicillinase. So these bacterial organisms do produce an enzyme which can destroy this antibiotic. So we again get this antibiotic classified as penicillinase sensitive and those who are resistant. Pseudomonas, as we saw, is a gram-negative rod, which we saw, which we saw in the previous classification, and they were the one which were most of the time not included in the spectrum. So then they developed another extension of this penicillin, the carboxylin, which was a ticarcillin and carbapenicillin, or piperacillin, which is very commonly used now as an anti-pseudomonal coverage. So remember, if you're suspecting or you're broadening the antibiotic cover, and if you are looking at changing from amoxicillin to piperacillin, it still makes a sense, because piperacillin is going to include pseudomonas, whereas amoxicillin may not be using pseudomonas. Now, let's see, once we started getting more and more resistant to penicillins, then the another group was developed. We call it as a cephalosporin. Now, in this cephalosporin, we gradually went from first generation to fifth generation. And as we go, and the reason for this generational shift was, as we grow from first generation to fifth generation, one, the spectrum was going high. Two, in spectrum particularly, gram positive to gram negative involvement was more. So first generation was more or less covering gram positive. Second generation also were with the gram positive ones, but the third generation started having gram negative organism, particularly ceftriaxone, which we were very familiar with. Fourth generation was mostly reserved for cefepime or pseudomonal coverage, or the resistant organisms, which are still very good in many of the countries. And beyond this, those who were very still resistant, we had a fifth generation. Now, once the resistance also developed on this, we had carbapenems. Remember, we are still at the beta-lactam, who are going to destroy the cell wall. So carbapenem again came up with a very broad spectrum, including gram positive and gram negative. We had meropenem, mortapenem, doripenem, and imipenem. Some had, we call it as, depending upon the structure. I'm not going in a structure of each of them. These things had a structural differences. So we had a monobiolactam. We have only one, that is an astrionam. Now, as we think we are smart, and the antibacteria were also smart, they realized that these beta lactams are tough nuts. So we need to develop an enzyme, and then develop an enzyme which was called as beta lactamase. So, and then that made all these antibiotic ineffective. So the humans, as we know, we are more smarter, supposed to be more smarter. We started developing an inhibitor for this beta lactamase. So beta lactamase inhibitors were introduced. They were sulbactam, tazobactam, and clavulanic acid. So now all these above antibiotics were combined with these beta lactamase inhibitors like piperacillin tazobactam, which is the very commonly used. We have ampicillin or ampicillin sulbactam combination. So all these combination came up with an assumption that the organism has a beta lactamase with it, and then the sensitivity increased. So remember, when you are using any antibiotic, it makes sense. So need not, for a community acquired or community based, you need not use sulbactam, you need not use tazobactam, you need not use clavulanic acid. You give simple basic antibiotic. If they are working, that's fine. You don't need to add anything. If they are not working, they are not responding, then you should think of going up. Now, these penicillin, cephalosporin, carbapenem, monobactams, and along with the beta lactamase were covering a very broad spectrum of gram positive and gram negative. However, the more focus these beta lactams were on the gram negative, because the gram negative had a more thicker cell wall with the lipopolysaccharide. The other group, which had no lactams, they were grouped as glycopeptides, and we have for that we have vancomycin and teicoplanin, which you have commonly used. However, the restriction of these glycopeptides are mainly for the gram positive with probably the thin wall things, or at least the gram positive, pure gram positive organisms, staphylococcus, streptococcus kind of thing, or enterococcus. Pure gram negative has been like polymyxin B or colistin, which we have. Now, this was the first group which would inhibit the cell wall synthesis. The second came up was a protein synthesis, where the classicals were, which were aminoglycosides and tetracycline. Now, aminoglycoside, you know, gentamicin, amikacin, neomycin, tobramycin, and streptomycin, which has its own spectrum, but they are primarily looking at the gram negative organisms. Then we have tetracycline, which we have doxy, TG, minocycline. They are all has a spectrum which prevents the protein synthesis and has an atypical involvement also. Then we have again protein synthesis inhibitors like linezolid. Then we have quinpristin, dalfapristin. I heard of it but never used it. Then we have chloramphenicol. We have macrolides like erythromycin, azithromycin, which is very commonly used, especially taking care of the intracellular atypical organisms. And then we have clindamycin and lincomycin. Those, the other one, we came up with the DNA synthesis inhibitors. We have the fluoroquinolones, and then we have first generation, second generation, third generation. So we go from first generation ciprofloxacin to levogati and ofloxacin. Now, one of the reason why, even though they are fluoroquinolones, why these are having such a different thing, what is the difference? Each one, either they are structurally different, or the concentration and the pharmacokinetic and pharmacodynamic. For example, ciprofloxacin was known to have a high concentration in urine. So urinary antibiotic, if there is organism is focused or concentrated in the urinary tract, then you are using ciprofloxacin. However, the penetration in the lungs was very minimal, whereas when it came to levofloxacin, or when you call the ofloxacin, there was a more lung or pulmonary penetration as compared to the ciprofloxacin. Hence, they were started getting preferred drugs for the pulmonary pathology. The other, we have a folic acid synthesis. So we have sulfamethoxazone and trimethoprim. So we usually get in them as a combination. However, sometimes you can get TMP as a separate drug. Then we have those which damage DNA. So we have only one in that. We have got a metronidazole, and then we have a mRNA synthetase inhibitor. We have a rifampin. So these are the broad classification, and they are not random antibiotics. They act at the different level, and we need to be very mindful when we are trying to use. The thumb rule always remains: if you know the organism, try to narrow your spectrum as much as possible. Beta lactams by default are called as a broad spectrum antibiotics, whereas as you go to the other levels, like say glycopeptides, protein synthesis, fluoroquinolones, sulfonamides, metronidazole, rifampicin, they are all, the spectrum keeps on getting narrower and narrower. So try to use the narrow spectrum antibiotic best to your clinical acumen, and leave the broad spectrum antibiotic to the situation where even you do not know what you're treating or what bacteria you are suspecting. Any questions so far? Anybody is there, or everybody left and slept?
All clear, sir.
All clear? So तो नहीं गए ना सब लोग? It's a boring one, but important. If you can, guys can download this chart. This is a very fantastic chart from Wellington Manual, ICU Drug Manual. This is very useful. It is in one chart, a quick reference, what is covering what for the important organisms. This is freely available on the internet, so you can easily take this. And you can actually print out a big poster out of this, and then stick it in your room, ICU, clinic, whatever you are, and then you try to use it. This is a good chart, I feel. Now, one of the biggest thing you come across in the bacteria now is a drug resistance. So you come across resistant organisms, and you're always confused what to do and what not to do. So when you talk about a drug resistance, you need to know what are the mechanisms through which the drug resistance occur. Why you need to know? So that you can bypass that mechanism. So the most common which we get is, as I spoke, beta lactamase. So we see that the drug gets inactivated by the bacteria by the release of enzyme beta lactamase. So we have beta lactam drugs such as penicillin, cephalosporin, carbapenems, and then they're affected by beta lactamase. And we know that we have beta lactamase inhibitors along with that. There are certain other drugs. So if you see in all these things, penicillin, why we people say that the penicillins are now useless drugs many a times, is because the resistance for the bacteria has come at a different level. You see that it one, you have a beta lactamase producing, in which penicillin is there. Then you have a mutation of the penicillin binding proteins, where again penicillin cannot enter. Then you go down, you have a reduced permeability of the drug through the porine proteins, again penicillin gets affected. So penicillins are the poor people who, even though they are discovered early, they are now losing the charm. However, they are still best if they are sensitive. Others, we have mutation in proteins, where we get aminoglycoside resistance. Then you have vancomycin resistance. Then you have a DNA gyrase mutation. So the thing about the quinolones is that they have a single point mutation. So if this DNA gyrase gets mutated with one exposure, then the whole quinolones, all the quinolones together are becomes resistant. The organism becomes resistant to quinolones. Then we have a specific rifampin and isoniazid. Now, rifampin and isoniazid, we use it in tuberculosis. Then porine protein mutation affects your aminoglycosides and others. And then we have a multi-drug resistant pump, which exports the drug from the bacteria. The moment the drug goes inside the bacteria, all these pumps will throw them out. So we have tetracycline, sulfonylureas, and quinolones for that. I'm going to quickly take you through what are the current, this is not a complete list, but important bacteria which are moving around in the community or in the hospital and its significant drug resistance. So we have a gram-positive cocci, we know Staphylococcus, Streptococcus, and Enterococcus, where we have penicillin resistance and we have vancomycin resistance. So when you come across these organisms, make sure that you cross-check your antibiotic and see that they are not resistant. Second are the gram-negative, which are very notorious. We have Neisseria gonorrhea, again, penicillin. We don't have, for gram-positive rods, we have none. Then we have gram-negative rods, so which is again the common win Acinetobacter, Enterobacter, Pseudomonas, and Haemophilus. See, Pseudomonas, Enterobacter, and Acinetobacter, they are all beta-lactam resistant. They are clinic and aminoglycoside resistant. And Enterobacter in particular are also carbapenem resistant. So you have to be very careful. Now, if you see this Enterobacter and Enterococcus, both are different. Both of them are found inside the intestine, but one is gram-negative and one is gram-positive. So you be careful when you're choosing your antibiotic. Then you have a mycobacteria, which we know resistant tuberculosis. Remember that Mycobacterium avium intracellulare, they majority of the time inherently are resistant to the most of the anti-tubercular drugs, except isoniazid and rifampicin, but they quickly go into resistance, and hence we have to be very careful when somebody says, oh, he's got microbacteria. So whether it's a Mycobacterium tuberculosis or whether this is a Mycobacterium avium intracellular, you have to be very specific. Now coming to the another aspect, while we have bacteria and we have antibacterials, we have also been successful in developing some medicines which can preemptively protect us from the invasion of those bacteria. And this medicine, we call it as a vaccine. The common vaccine which you need to know or should be aware are for the following organisms, that is diphtheria, tetanus, whooping cough, meningitis, pneumonia, and again H. influenza and Neisseria meningitis. Now we use various components of the bacteria. For example, for diphtheria, tetanus, we use toxoids. Then some like pertussis, we use purified proteins. Some have capsular polysaccharides, and then we have again some capsular polysaccharides. So all these importance is, one, for kids and babies, we do have a national program where we have diphtheria, tetanus, and pertussis. However, the reason you need to know these things is there are few situations in adults, like splenectomy patients or immunosuppressed patients or elderly patients, whom you would like to give these vaccines so that their susceptibility to these organisms is less. Because these organisms, for example, bone marrow transplant patients or those patients who are on newer chemotherapy or newer MAB therapies, some of these patients need to be vaccinated like for a H influenza or Neisseria meningitis, because if these immunosuppressed people are exposed, then they are very lethal and they will die. Certain special situations, especially those people who are giving MRCP and those who are going to live in UK, US, or Australia, they will be, if you go into the GP, then the travel vaccination becomes a important. So when you go to an endemic, you ask them when they go for a travel, you tell them to take these vaccines, typically salmonella, cholera, plague, anthrax. Tuberculosis is a BCG vaccination. You don't tell them, but it is in our national program in India. Then you have some typhus and Q fever vaccines are also available. So these are the list of the common bacterial vaccine that you need to give to your patients. I think that's where the bacterial vaccine indications we have. We have a routinely administers, we spoke about it, and then for individuals with a high risk specific epidemiological context, we just spoke about this. So this ends our bacterial aspect of it. Any questions or too much of information? This is just an overview, just to, I know most of you might be knowing it, just to keeping a perspective. Should we move ahead? Hello.
Yes, sir.
Okay. So the next ones are the viruses. Now I'm going to keep it very simple because we don't have much of the staining and all those things. So basically, broadly speaking, this is, again, it's not much relevant for you in a clinical practice, but there is something called as DNA virus, and then we have an RNA virus. And when we have this DNA virus, mostly we have adenovirus, papillomavirus, hepadnavirus, herpes, pox, parvovirus, and then we have an RNA virus where you have our famous coronavirus. So this is just medically relevant viruses. Not that you need to remember the classification. As we have antibacterials, we have antivirals. Now, viruses are a very tricky organism. First of all, they don't have much of their structure, and they are heavily dependent on the host cells for them to multiply. So it becomes very difficult to target any virus in particular. And when this becomes difficult, then we look for how this virus multiply and survive. And that's where the targets come through. And when we talk about this, these viruses essentially get into the host cells, and then they utilize the DNA, RNA of the host cells, and then they come out. So this steps of the viruses become very important target. Manoranjan garu. Yeah. So and that's how the antiviral. So as against the antibacterials, where we specifically target various structures of bacteria, we don't have much choice in antivirals. So what we target is the entry path and the intracellular path. Why this is important to know? Because here our host cells are involved. So these antivirals will have more side effects. Because these antivirals are going to affect the host cells. because that's where the viruses are there. And hence we are going to see a uh, more of a kind of side effect with the patients taking antiviral as compared to they taking antibiotics. So antivirals will be specifically targeting the stages of viral replication, and these stages start from early events, that is entry or uncoating of the virus. And the examples, you don't need to remember all these antiviral drugs. These are the just drugs which affect through this particular stage. So this table essentially is give you an idea how these viruses are targeted. Now, remember, as with the bacteria, there are different kinds of viruses. There are millions and zillions of viruses, and we haven't been able to um, even even take care of what we call a fraction of it also. So these viruses, again, fraction of viruses, they keep mutating, they keep changing. So 50%, not 50%, I would say 90% of these drugs become ineffective. We have been got we do have some success in some viruses which are very specific, like the viruses like hepatitis B virus, hepatitis C virus, we have HIV virus. These are all because of their behavioral pattern inside the human beings we are using and targeting. Again, if you see for say HIV virus, see the long list of antivirals we have. So it is very clear that one particular antiviral is not going to destroy this virus, but we need a combination of the viruses. Few of the viruses which we have been able to what we call as prevent, or we have been able to get a hold of, is the herpes virus, where you have a specific acyclovir, ganciclovir, valacyclovir, so on and so forth. And then we had this SARS-CoV, we had this remdesivir coming up. Again, now we come across this SARS-CoV-2, that is coronavirus 2, that was a specific one. Now, if that gets mutated, again, this is going to be a useless one. There are few antivirus like ribavirin, which probably as a blanket will decrease the efficiency. Then we have for particularly for HIV, where we have polypeptide cleavaging of the precursor of the polypeptide. The most difficult of the viruses are the RNA viruses, because they don't even have a double strand, they have got a single strand. In which case we do have interferon, we have lenacapavir. Few of the influenzas, oseltamivir, are there, but again, we use them, but the efficiency is questionable as we move forward. Same, we've got these antiviral drugs specifically. Now, the HIV drugs we had covered during our previous talks, which was specifically on the HIV. So I'm not going to touch that in detail. This is the pictorial presentation of what I was talking. So all the big table which you have seen is specifically targeting these stages of the virus. So as you can see, it's not for a specific virus. There are different viruses come through a different way, but these are the common factors of all the virus. One, we've got a virus which got a peripheral wall. They attach to the receptor, and then the inner viral component, they get uncoated and they enter, and then they multiply with the mRNA, with translation and transcription, and then they multiply, they become more and more, and then they come out with the cover from the cell. Now, in this process, either the cell is completely destroyed, as what we see in HIV, or the cell remains ineffective, and it doesn't get completely destroyed, but it becomes dysfunctional. For example, in multiplying a long-term HCV, you end up people getting cirrhosis. So the antivirals which we saw is where these are the various places where they get they act. So initially we spoke about, say, for example, respiratory syncytial virus. So palivizumab is going to prevent the virus from entering your body. Then for, say, for influenza, we've got amantadine that prevents its uncoating. Then we have for hepatitis C virus. So hepatitis C virus, we don't have anything to enter and uncoating. However, we can prevent it from multiplying. Same thing for the SARS-CoV. And then we have other nucleic acid synthesis inhibitors. So antivirals, even though you may not remember, but you need to have an idea where these antivirals are working and how these viruses enter into body and come out. As I said, the most common thing which we come across and which has been consistent has been the herpes virus. So this figure helps. We have got acyclovir, valacyclovir, then we have a ganciclovir, which has slightly bigger spectrum than acyclovir. It includes not only HSV and varicella zoster, also includes CMV and human herpes virus 6. Then we have foscarnet, which again has a bigger spectrum, and then we have a cidofovir, which will have, so the spectrum of the antiviral goes up as we go up from acyclovir, valacyclovir to cidofovir. Again, I got this picture. I liked it. It is a mix for HIV, herpes simplex, and HPV, HCV treatment. Not many players around, but these are the few antivirals which are there. Most of the time they are treated by the specialist, maybe at the primary level, the RSV and the influenza, that is what we are looking at, and we will be using, say, oseltamivir. Sometimes we might have to follow up with an HIV patient, for which we might have to know what are the antivirals which are relevant to the HIV. As I said, there are few viruses which we have been consistently been able to suppress using the medicines. So we have, again, herpes simplex virus and CMV virus, where we have acyclovir, ganciclovir. Then we have oseltamivir for the influenza, and we have other letermovir for CMV. Then we have for HIV infections, which we have zidovudine and tenofovir. There are multiple combinations for neonates and needle streak injury. And then we have a pre-exposure and post-exposure prophylaxis for HIV. The third one is a fungal. I'm going to go through it quickly. Now, fungal infection becomes very important and relevant, especially now with we are having transplant, solid organ transplant. People are on high dose steroids and the MAP therapy. It's very important because in fungus in particular, there is no one drug there is nothing like a broad spectrum antifungal. We do have few of them, but it's very tricky if that fungus is not covered. So classification of the fungus and its presentation is important, and then that leads to a choice of antifungals. So the fungus which are medically relevant and which can kill the patients, can be classified one as molds or filamentous fungus. The common examples being Aspergillus group and mucormycosis group. So remember, these two are very notorious. They cause not only pneumonia but also disseminated infection. Mucor is in particular is a very terrible one, and its mortality is very high. The risk factors, they are neutropenic, steroids, hemopoietic stem cell transplant. Um, Lately, aspergillosis has been quite found in post-COVID. Uh, Atopic in both the cases. Those who are badly diabetic, we had a case who was a diabetic lady who was elderly, and she came with what looked like an asthma. The little bit of mediastinum was wide. So the respiratory guys treated her with a high dose steroids, pulse steroids, and she kept on worsening till we got a CT scan. To our horror, to see there was a mucor sitting in the anterior mediastinum. Ultimately, she died. It was too late, but that gave us a lesson that little bit of doubt and not responding to the routine therapy within 24 hours should be evaluated. Now, aspergillosis, it's very difficult to grow in the bowel fluid. So culture is not the way we diagnose it. If we have a tissue sample, we can get it as a histological examination, we can get it. But primarily, we have a galactomannan and serum beta D glucone. Now, serum beta D glucone is non-specific, but galactomannan found in bowel is more diagnostic as compared to serum. Coming to mucor, again, it's very low sensitivity. It's very difficult to grow in culture. You can, most of the time, it's a diagnostic in histological tissue examination. They don't have much of biomarkers to diagnose mucor. It's either clinical, radiological, and histological tissue where you look for the mucormycosis. The other things in the molds, we don't come across much, but we do have fusarious and scedosporiosis. I haven't come across with any of them. And then these are commonly molds which are found in neutropenic patients. Again, the biomarkers are galactomannan and beta D glucone, and most of the time histological examination is the one which we come across as a we are told by the microbiologist that these are the molds which are found. The next important fungi are the yeast fungi, and we call it see it as a candidiasis. So we have a mucosal candidiasis and the invasive candidiasis, which we are very worried about, especially in an immunosuppressed patient. So when you have a mucosal candidiasis, that is a oropharyngeal candidiasis or vulvovaginal or esophageal, they are slightly different. So Candida albicans and Candida glabrata are the one which you will be finding them. But when it becomes invasive, when you grow in the blood, Parapsilosis, tropicalis, and auris. These are the three candidiasis which gets added, and they can kill the patient. They can come as a pneumonia, osteomyelitis, etc. Typically seen in intensive care, neutropenic patients, AIDS patients, high-dose glucocorticoids, high antibiotic broad spectrum usage. Remember, this is very, very important. The patient has been on meropenem, then tigecycline, colistin, and whatnot, and ceftazidime, avibactam. The patient is on and on, going on with, we are giving, patient is not improving, and we are keep on adding the antibiotic. When you reach to this kind of situation, think whether my antibiotic has induced any candidal infection, and then start searching for them. Now, most of the time, these candidiasis are flagged in our routine culture. You don't need to send a specific culture for them. You don't need to have special stains nowadays for them. These candidiasis sometimes get detected even in the gram stain in the peripheral smear. So be behind your microbiologist or the pathologist, mostly the microbiologist, who is seeing the slides to see whether the unusual candidiasis is picked up or not. And this becomes very important. Nowadays, the modern blood cultures are capable of detecting this candidiasis and species classification. The next one are the cryptococcus, very dreadful, typically seen in AIDS patients or autoantibodies or those who are on the MAB therapies, those fancy immunosuppressive drugs, and they come as a meningococcal encephalitis, a very dreadful disease. I've seen a couple of few culture of CSF, bile, fluid, blood, sometimes CSF. India inks is the one through which we can get it. You need to specifically tell this to your microbiologist. Biomarkers now we have available. A cryptococcal antigen in serum or CSF is also sufficient to diagnose. I have not seen trichospornosis, but they apparently cause disseminated infection in neutropenic glucocorticoids and hematopoietic stem cell transplant and solid organ transplant. Histosplasmosis and blastomycosis are some differentials you will come across for the pneumonia when you're treating an immunosuppressed patient, and it will be a differential for your tuberculosis. Same self-limited pneumonia, disseminated infection, they are a little bit less lethal, has some propensity to those who are immunosuppressed, but can also happen in a healthy individual. Again, as I said, these are the differentials which you will get as a part of differential diagnosis of tuberculosis when you are dealing with. We do have a few biomarkers. Culture and histological examination are not very helpful. We do have a histoplasma antigen, and we also have the serology for blastomycosis. Same coccidioidomycosis, same as a blastomycosis, histoplasmosis, coccidioidomycosis, they all fall in the similar category of the patients causing pneumonia and disseminated infection. Other sporotrichosis and telaromycosis I haven't come across, I haven't seen them, but then you see them more in the immunosuppressed patients. So to treat this this fungal, again, the principle remains the same, what we saw in antibacterials. You look at the fungi, they are better structured as compared to virus, but they are a little bit weaker as compared to antibacterials. So it's very easy. Either you disrupt the cell membrane, or you inhibit the formation of the membrane, or you inhibit the cell wall synthesis, or inhibit the inner DNA synthesis. So in this, that is how we have classified. Broadly, we don't have many antifungals. So we have got an amphotericin B, then we have an azole group, and then we have an echinocandin group. So this is a little bit better off when you are initiating it. Yes, there are few other like flucytosine and terbinafine, but by that time we are either calling infectious disease specialist or ICU guys to involve. So we have just a quick look broadly. We have antifungals which we use intravenous or oral. Not all of them we can use, and some we use only topical. Commonly, the famous drug is amphotericin B. It has it's more famous for its toxicity rather than its advantage. It is a beautiful drug, and however, it has a lot of renal toxicity and side effects which we need to be aware of. Then we have fluconazole, ketoconazole, itraconazole. I'm going to talk about the spectrum in the next slide. This is just an overview of what drugs we have. Then we have caspofungin, micafungin. Then we have flucytosine, which all other drugs seems to have a bit of a lesser toxicity as compared to amphotericin B. The topical ones are, to be very honest, we use it left, right, and center. For the azoles and nystatin, they're very well tolerated on the skin. Again, I love this chart because most of important groups of antifungals are covered, and important fungi are also are listed here. So we have yeast, we have molds, and then we have dimorphic. Mostly what you will be dealing will be the yeast and the mold. So we have an amphotericin B, which covers almost all all candidas, cryptococcus, and aspergillus, except aspergillus terras. Now there is one more candida, which is a candida auris, which is not susceptible to amphotericin. I forgot. I think it's susceptible to echinocandins only. Then we have azoles. We have itraconazole, voriconazole, and posaconazole. We do have few more azoles, which has a broader spectrum. So they most of the time cover candida. However, the invasive candida, particularly glabrata, are not covered by azoles. Now, if you look at echinocandins, they cover most of the candidas, including Candida glabrata, and they also cover the aspergillus. So if you have to start a broad spectrum candida antifungal, then I think echinocandins are the one. As per the latest guidelines, again, that has scored over the azoles, that echinocandins have become the first line of treatment. Of course, they are intravenously available. We don't have oral forms of that. The oral forms, if you are using, then you are looking at voriconazole or posaconazole. You can use. However, keep in mind that Candida glabrata is not covered by this azoles. Otherwise, if you're going for intravenous or parenteral, then you have echinocandins, which are covering most of your antifungal. So I think this brings to the end of the first talk. So in next talk, we are going to cover sepsis, septic shock, its recognition, its guidelines. What are the antibiotic adjuvants you use, and I will also try to cover the infection in special situations. I'm happy to take any questions. All right, then, happy to lag out? Hello? All right, then, I'll log out. Thanks for having me here today.